Just going to talk a little bit about some of the work that my team has been doing. Here are my disclosures, some of which are directly related to what I'll be talking about. So first, I'm going to talk a little bit about AI and ICH, and then a bit about the recent developments in terms of ICH surgery, and then some of the trials that my team has been involved with. So as you all know, ICH accounts for about 10 to 15% of all strokes. It has the highest rate of morbidity and mortality compared to other stroke subtypes. ICH-related injury is divided into two stages. You have primary injury and you have secondary injury. So for the primary injury, that's usually at the time of hemorrhage, and you have physical disruption of the tissue, mass effect, and is often considered untreatable. Then you have secondary injury where there's pathological changes in and around the hematoma leading to edema. About 1/3 of ICHs go on to have expansion, leading to midline shift, neurological deterioration, and worse clinical outcome, and that's potentially preventable. And most of the expansion occurs within a few hours after the initial CT scan. And in literature, most studies have considered 33% relative or 6 milliliters absolute as the definition for expansion. And that corresponds to about 10% increase in terms of diameter of the sphere. Now, in terms of secondary injury, this develops relatively quickly after ICH and peaks several days after, and it can lead to increase in ICP. In human studies, the edema develops within about 3 hours and peaks about 10 to 20 days. But the highest rate of increase is around 24 hours. The edema volume is associated with poor outcome and is a promising surrogate marker of secondary injury. And this is just a schematic of what secondary injury process is. Immediately you have increase in colloid osmotic pressure that draws fluid into the ATP depletion, leading to cell membrane pump failure and therefore cytotoxic edema. You have conversion of fibrinogen to fibrin, blood-brain barrier disruption, complement activation, and later, about 3 days, you have breakdown of red blood cells with free radical generation, apoptosis, and neuronal death. So first, the important thing in patient selection, in a lot of the studies have been, measuring hematoma volume. That kind of determines whether, the patients qualify for the trial or they're excluded. But there's not a real gold standard in terms of quantifying edema. The manual slice-by-slice segmentation is usually kind of the consensus gold standard, but that's unrealistic in terms of large samples, and it requires expertise and it is very time-consuming. There's also semi-automated method, which is more widely used, but still very time-consuming, and it's not a validated method either. So there is a need to develop a fully automated method that can do this accurately and efficiently. Same thing for edema quantification. It is a promising surrogate marker, but it has similar Hounsfield units on CT compared to CSF or microangiopathy. So it really limits threshold-based edge detection edema quantification algorithms. So there's also a need to develop a fully automated method that can do this accurately and efficiently. So first, we tackled the quantification of the hematoma. And so we took 300 ICH patients from the Columbia database, and we divided that into training and testing. So the algorithm was trained on 357 manually segmented scans. And, we got pretty good results. So this is in the test data set. The dice coefficient, when you compare fully automated to manual and fully automated to semi-automated, that value is very close to 1. And this is just a kind of example of what that looks like in terms of segmentation. So on the left, you have the original, and then you have the manual, and semi and automated, they'll look pretty similar. But if you look at the time that it takes to quantify these, for the fully automated, it takes about 12 seconds per scan. And this is compared to over 200 seconds using manual or semi-automated. And those differences are significant. And in terms of the quantified volumes themselves, there's not real difference between all those methods. And here are the strong correlations between the various methods, the intra-rater as well as inter-rater correlations. And then we went on to look at edema quantification. So similarly, we took 400 ICH patients from the Columbia database, and we trained this on 464 manually segmented scans. And on the test data set, you can see that value is also fairly close to 1, the Dice coefficient, when you compare automated versus manual or semi-automated. And here's an example. Here are the examples for these different quantification methods. As you can see, they're all very similar in terms of what you can visualize. And again, the fully automated took about 18 seconds per scan, versus manual or semi-automated, those took at least 300 seconds. And those differences are significant. Then if you look at the volumes that are quantified, and they're fairly similar, there's not a significant difference amongst those three. And these are the various methods that are strongly correlated, and inter-rater as well as intra-rater correlations are also very strong. So we were able to develop fully automated hematoma and edema segmentation algorithm that has high fidelity and also greater efficiency when you compare it to manual or semi-automated methods. So these validated well internally, but how do we validate these externally? And so we went on to design a prospective study called quantum study, where we try to validate this using an equivalence design. I'm not going to talk too much about the statistics, but suffice to say that the traditional measures of agreement, such as Blenalbin or even Dice coefficient, you can't really establish equivalence. And if you fail to reject the null hypothesis by showing that there's no significant difference, that is also not a valid evidence for equivalence. And so, we designed this prospective randomized study with the objective to determine if the fully automated and semi-automated methods provide hematoma and edema volumes on CT scans that replicate those of the manual method within a clinically acceptable margin of error. So we de-identified CT scans from the VISTA database, and we included ICH, supratentorial ICHs with available scans on admission and also day 3. We had 126 patients, total of 252 scans, 126 on admission, 126 at day 3. We have 6 raters who prospectively quantify hematoma and edema volumes on each scan using both semi-automated as well as manual methods. And of course, these scans were also quantified using the automated method. So the scans were allocated to each rater in a randomized order that is unique to the rater for quantification. And after quantifying the volume using first method, the raters then crossed over to the second method. And the raters were blinded to each other. Investigators, statisticians were blinded to raw data until completion of the study. So edema and hematoma, they were quantified concurrently, but analyzed separately. So our primary outcome for the hematoma portion is the admission hematoma volume, because it's important in terms of patient selection. And for the edema, we chose the day 3 volume as our primary outcome. And we had our secondary objectives, looking at the time it takes, similarity of images, inter-rater agreement, and our pre-specified subgroups by volume, location, as well as IVH. So we tested for hypotheses, and for both, two for hematoma and one for edema, really looking at equivalency between automated versus manual and semi-automated versus manual. So if the fully automated and semi-automated are both found to be equivalent to the manual, then we go on to do a superiority test and to differentiate the two methods. And if that's rejected, then that will allow, if the no is rejected, then that will allow us to differentiate the methods to see which one is actually closest to the manual method. And we chose a margin of 7.5%. This is really based on the kind of the recommended clinically meaningful outcome effect size for ICH intervention trials. A 10% difference in terms of hematoma volume translates to maybe about 5% difference in terms of mortality. And so that's why we chose a 7.5% margin. So, we powered this really to look at equivalency, and it's a relatively new design in terms of clinical trials. Most trials, are looking at efficacy, right? Right now, the study's complete, but we're trying to finish the data cleaning so that could be analyzed. Okay. So, yeah. Okay, so the next step here, really, after that, is to look at hematoma and edema expansion, because they're potential therapeutic targets, but really lack a reliable and robust prediction tool. Current trials really did not select for patient at risk for expansion, even those that specifically target expansion, like the FAST trial and also the TXA trial. And as you can see there, in the TXA trial, the placebo only, in the placebo arm, only about 29% of the patient has expansion. So, the patients in these trials are really diluted by those who are not at risk for expansion. And so there is a critical need to really identify these patients who are at risk for either hematoma or edema expansion. The goal is to develop a machine learning approach that can quickly and also accurately predict hematoma and edema expansion. So the published scoring systems that combine CT and also clinical information have not really impacted decision making, because they're mostly retrospective from retrospective single center data and require medical knowledge in terms of implementing this, or there's a lack of connection to the underlying disease pathophysiology. So, methods like, end-to-end methods like deep learning, you can't really, the user can't really access the structure of the algorithm. So it's really hard to understand what exactly is going on. So, we took this, in a slightly different approach, using a mathematical approach of using optimal mass transfer. So what is optimal mass transfer? It's really, it seeks to identify the most efficient way of transforming one distribution of mass into another. And transport-based morphometry is a technique that allows this image transformation, and this can be applied to model hematoma expansion. So essentially, it solves for a formula that transforms ICH in this initial CT scan into the ICH in a follow-up CT scan. So for this study, we included patients 18 years or older with CT scans with ICH within 4 hours, and a subsequent CT scan at 24 hours, supratentorial ICH, and also initial volume of 7 or greater. We excluded those that had surgery and those that with primary IVH. And if we were to, categorize these into the ones that end up having expansion and those that do not, you can see that the baseline characteristics are pretty similar, with the exception of hematoma growth rate as expected. We shuffled the data and separated that into 60% training, 40% testing, and it was cross-validated 1,000 times. So we segmented all the hematoma on the CT scans, And if we were to categorize these into those that end up expanding and those that did not, just visualizing this, you aren't really able to tell, which one will have expansion and which one won't. So we took the training set, the initial scan and 24-hour scan, and basically developed this algorithm that helps us categorize those in terms of imaging features. Now, what the algorithm tells us here is that the ones that have least risk of expansion would look something like the one on the left side, and the ones that are at high risk of expansion looks more like the one on the right side of the screen there. And if we were to try to put these into words, the larger size ICH is the one that look elongated, have peripheral density distribution, and more heterogeneity are the ones that tend to expand. And we also then looked at, in terms of location, does that really matter? And the ones that are more posterior, inferior, and medial, i.e. in the thalamus or pelic, are the ones that tend to have higher risk of expansion. And so how does this perform? How does this algorithm perform compared to all other existing prediction scores? And it outperformed actually compared to all these other scores in both the testing data and the training data. So here are the area under the curves. With this with the TBM method, you get about 0.7 in terms of area under the curve. And so, what we can say is that TBM is a better tool in terms of predicting ICH expansion compared to what's currently available. It's fully automated. There's not really need for expert input. And it may allow generation of hypotheses as to the mechanisms that drive ICH expansion. The intensity distribution towards the periphery may be early phase of a continuous process of expansion, or certain location structural properties may facilitate expansion. So here, in terms of future steps, is to externally validate and improve the algorithm in a larger sample size, such as using the ERIC database, or and also using a fully automated segmentation method that will be through the quantum study to feed this algorithm the segmented scans, and then finally to use this in a clinical trial setting. So I'm going to switch gears a little bit and talk about surgery and and kind of the recent development. As you'll know that we have this BrainPath NICO device here at TMC, and some of us have used it. So this is the obturator that goes in the sheath. It's aluminum finish. It glides across tissue. The obturator tip radius is about 0.5 millimeter, and the angle is 30 degrees. It offers smooth transition from the tip of the obturator to the sheath. And it's got these rounded ears that allows venting. And the internal part of it is cored out also to facilitate venting as well. And at the end, you've got the screw that can secure the navigation probe. And here's the sheath itself, made of resin polymer, minimizing resistance in terms of cannulating the brain. And it's got this tapered kind of distal end, and that allows for the smooth transition, frosted interior that facilitate light delivery. And there's a lot of lengths that's available. I tend to use a 95 or 75 millimeter lengths, and the 13.5 millimeter diameter, so I can use two instruments. So I'm just going to talk a little bit about the how do I do this? Oh, there we go. So, yeah. So this is some case examples. So this 80-year-old guy who basically woke up from a nap with headache and then started leaning to the left, and this large right side ICH and then he declined in the ED and had an ICH score of 4 at that time point. Family actually didn't want any open surgery, but had explicitly asked for minimally invasive surgery. So this guy got transferred here to TMC, and I think I used a 75 millimeter for this one. And he actually made a great improvement. Was able to be extubated after 2 days and went from EBD. Eventually went to rehab. I actually saw him back pretty recently, and he was neurologically intact. I mean, he was doing excellent.
What's your goal when you put the sheath in? How much do you want to take out?
Yeah, so this, so my goal really, is to have, less than 15 milliliters residual. But the thing is that with this, it also depends on your trajectory.
Do you weigh like what you get out? Like, how do you know how much is left?
Well, usually, whatever that falls into the field, you can kind of get a sense of whether you got everything. But for this going in, I mean, I knew I was not going to be able to get everything because the trajectory itself, right? This wasn't like a kind of a elongated shape. It was kind of, more kind of it's not a very regular shape.
Right, it's irregular.
So I knew going in that I was not going to be able to get, most of it out. But the goal really for this one was kind of the deep portion of it. I wanted to get out, and mainly for decompression for this one.
Did you do this one through a parietal craniotomy?
I think it's more frontal.
Because it looks like there's a crop. Looks like there's a.
Oh yeah, it's like right here.
Yeah,
it's like right here. Yeah, but it wasn't like back here, but it's right here. I mean, this one I couldn't do it, like the deep ICH where I usually go through right here, because of the shape of the hematoma itself. And then, next one, I'll show you this one. This one I was able to do it kind of the traditional way of, because you can see here that this hematoma is, fairly regular, and you've got this long axis. Oh, I guess you can't really see. How do I pointer? But anyways, you can see that, there's kind of a long axis to the hematoma. So, the best trajectory for this one would really be, right in the frontal. So this is that's what I did. And for these, usually you have to use a 95 millimeter sheath. And this guy did well as well, but he didn't really follow up, and most of these patients end up just not coming back.
I'm sorry, you make an incision on the forehead?
Yeah.
An eyebrow incision, or
No, just right here. So actually, I used to do it like behind the hairline and flap it down and do it through here. But then came here, and then Yasha's been doing it this way. So I was like, well, that seems
what's the outcome of that incision? What is it? Yeah, that's like you look like Frankenstein, right? At that.
No, actually, I saw the first. Well, I mean, I've seen like one back, and it actually healed pretty well.
Yeah, it's not very good.
Yeah, I mean,
it
heals pretty well.
Yeah.
That will do it like that, and it heals well. I've seen one in clinic.
So I don't use like Sapos. I use Fasca, Glyco Fasca for these, and they actually heal pretty well.
Jared, so one of the critiques for the NICO has been the disposables cost.
Yeah.
For every time that we do this case, because it's $10,000 worth of disposables plus or minus from what I gather per case.
Yeah.
And it sounds like what we're primarily using for the NICO is the sheath and the
obturator.
The obturator.
Yeah.
And then everything else, we don't seem to be using a lot of bells and whistles of the set. Is there any thought of potentially? Is there any way that we could jury rig something ourselves such that we don't have to depend on $10,000 of disposables for these?
So I think most of the cost actually comes from that Myriad device, the handheld suction cutter thing.
Sure, but we're not using that very frequently, are we?
No, but originally they came in a single package, right?
Sure.
Even if you don't want to use it, it comes with it.
Yeah.
And so you have to open both, right?
Yeah.
But from recent conversation with the Nico people, they said we could get just like the sheath itself, which I think will be, less costly.
Okay.
Yeah, but I agree. I mean, to me, I don't use the Myriad device. Yasha also doesn't, because it's actually pretty crappy, so, yeah.
Because it sounds like, I mean, theoretically, I mean, we could even use just spine MIS2 if we actually needed to. I mean, like we.
Probably, yeah. But, yeah, I mean, I've not used it, but we could try it.
The Nico device is terrific for intraventricular hemorrhage. I use it frequently.
Yeah, that's nice, yeah.
To do what, to
Suck it out.
evacuate it?
Pre-meet IVH, when we're going in and doing endoscopic third ventriculostomy cord plexus coordination, sometimes there's a big clot. We go in with the Nico and gobble it up. You gotta be careful because.
You mean the Myriad portion?
Yeah, the
of it?
Myriad, yeah.
Oh, okay. I
great
don't
for
use the
colleagues.
Myriad
It's
thing.
great for colleagues too.
Okay, yeah, I mean, maybe something that's a little bit more like, difficult to get out. I think probably the Myriad device works. But I just never really need to use it for ICH. And, Yasha also says the same thing. Yeah. And, this last example case, this guy didn't end up doing so well. It's a pretty big ICH and, he was not doing, he wasn't doing very well. Yeah, so here's the post-op on this last case. He didn't, this guy, pretty good evacuation. At 1 month, there's, minimal swelling. Imaging wise, I think it looked pretty good. But, clinically, he didn't do well. And as you all know, last month, the Hemorrhage study finally came out. And, they include patients age 18 to 80, supratendular ICH, volume 30 to 80, GCS of 5 to 14, stroke scale greater than 5, and eligible for surgery within 24 hours of last known normal. Their primary endpoint is utility weighted MRS and 180 days. They used a Bayesian analysis rather than a frequentist. They determined a clinically meaningful effect difference of 0.075 between groups with a pre-specified posterior probability of 0.975. So during the study, they had two parts to it. They had the by location, so they had the lobar hemorrhages and also they had the deep hemorrhages. And unfortunately, the deep location, they actually got stopped for futility. So it was basically a trial looking at the lobar hemorrhages. So here are their results in case the you guys have not read it.
Pre-specified the idea of doing subgroup analysis for lobar versus deep? Or was it something?
Whether that was pre-specified? Yeah.
They're two groups that they,
Because, it's almost irrational, right? So we're gonna use a tube to go deep inside the brain.
No, I agree. I mean, that's right.
But by the way, it doesn't work for those deep hemorrhages, but these superficial hemorrhages that you don't actually need a tube for, it works very well.
Yeah.
And there's lots of other data that suggests that lobar hemorrhages actually do well with evacuation.
Yeah, this original Stitch trial, yes.
In this company and everybody else is, oh yeah, we've got a positive study because of our device. It's a non-good device.
Yeah.
It's a disease.
Yeah. I mean,
Intervention for lobar hemorrhage makes a difference. Intervention for basal ganglia hemorrhage makes much lesser difference. And so you either have to do an extremely great job or choose really well or have a very large population. And it's very hard to study to prove
It's a
it.
shame there wasn't another arm for microsurgical evacuation.
Well, that failed though, right? Some years ago.
It did, but
Poorly done study.
correct. So now you're left with this,
Islamabad study,
Assume.
wasn't it?
yes.
Yeah. So basically here are the results, as you can see, if you look at the overall MRS, so for the surgery group, you have 0.458 versus control of 0.374. And, the absolute difference is 0.084 and that, exceeds their threshold of 0.075. And so their posterior probability is 0.981. So significant in terms of their overall finding. But if you break it down and look at the basal ganglia group, there's not really any difference between the two groups. For the lobar, it's 0.127 in terms of difference. So that's what's really driving the overall results. But overall, you have shorter length of ICU stay, shorter hospitalization, and in terms of reduction, percent reduction in hematoma, they got about 73%, and hematoma volume after completing the surgery is about 15 cc at residual. In terms of days of being on ventilator, you have significantly fewer days, much less likely to have decompressive crani, and the volume after the percentage of patients with volume of less than 15 cc after the surgery is about 73%. And here's just another depiction of their results. You have the MRS scores up there, and then you also have the distribution of their treatment effect. And here's their safety endpoints. 30-day mortality is much lower for the surgery group versus the control group. So their conclusion is that among patients in whom surgery could be performed within 24 hours after acute ICH, minimally invasive hematoma evacuation resulted in better functional outcomes at 180 days compared to medical management. And in fact, surgery appeared to be attributable to intervention for lobar hemorrhage. Again, as we were just talking about, because the deep ICH had neutral results, so is brain tap actually necessary for the lobar? And I mean, personally, I don't think so. I don't think for the lobar hemorrhages that comes close to the surface is really necessary to use a brain path device. But does this mean that we shouldn't do surgery in patients who have deep ICH? I don't think so either. Personally, I don't think the trial has really affected how I practice. For patients who have large and deep ICHs, with significant mass effect, causing, decline in mental status, I would still do the surgery. I mean, I would still use the NICO device because it's a much more elegant surgery, and also it reduces, hospitalization, the number of days in the ICU, and you don't have to bring them back for cranioplasty. It does everything in one surgery. In terms, they did not really provide subgroup analyses for, lobar and deep separately. So, maybe in their post hoc analysis, they will come out with the results for those.
Last time I spoke to Gustavo Pradia, the PI, they're thinking, I don't know what's going to happen, second trial just for the deep ones.
Yeah,
but
what was the outcome measure for the ICH evacuation for the deep? What was like their metric for clinical outcome?
Like endpoint?
Yeah.
Primary endpoint, it's the same. It's a utility weighted modified Rankin at
modified Rankin?
Yeah.
Modified Rankin is a rough score.
Yeah.
Same with subarachnoid hemorrhage and vasospasm and DCI.
Yeah.
You wonder if you had done more sophisticated neurological testing on a lot of these patients, whether it would have shown some benefit.
Yeah, probably. But I think like the NIH and the FDA requires it to be.
Oh, yeah.
That's why.
And it's also more timely, costly to run these more complicated neuropsych testing and all that stuff.
Yeah. And this is another device that's basically like the NICO device. The difference is that it's got a camera that's like mounted on the sheath itself. So, you don't have the hands getting in the way if you're using microscope, and better lighting in terms of this. And, this is made by Integra, and we're trying to get this at Memorial City because they said no to the brain path device. But, who knows, this might take another 6 months.
Is this cheaper? No, probably not.
Probably about the same. I don't know, but they're supposedly they are moving along with this at Memorial City, so I guess.
Is this reusable or disposable as well?
I think most of it is reusable.
All had to be disposable. That's the only way you're gonna make.
Well, it doesn't look like it, right? It's all metallic, so.
There will be part of.
Yeah, there are parts that
equivalent
are.
price going
Yeah.
out.
The operating cost is disposable. So that's a problem, you know, what, you guys were talking about the Mazer cranial. I mean, it's like the disposable cost is more than, you know, it's like $4 or $5 grand.
Yeah.
And and if you think about it, it's a little piece of aluminum, little
Yeah,
piece
it's
of
totally
plastic,
absurd.
like,
You can machine.
insane.
Yeah.
This is the part probably.
Yeah, this is probably the most
disposable, this part.
Yeah, so I mean, you know, they say that this, I haven't used this yet, but they say that this is better because it's, you know, got this irrigation thing and it's got a, you know, ability to coagulate. I mean, I don't know, we'll see.
This I think is evolved from Penumbra as the version.
Yeah, the what's it called? Apollo. Yeah. So lastly, you know, what about medical therapy? You know, my group has looked at a variety of agents in terms of targeting secondary injury, and you know, we looked really into statins, and you know, as you all know, it's an HMG-CoA reductase inhibitor that leads to down regulation of farnesyl pyrophosphate, and then it can affect cell proliferation, adhesion, migration, cytokine production, as well as reactive oxygen species. You know, it has a lot of effects, mainly affecting T cell, regulatory T cell, suppressing monocytes, macrophages, improve endothelial function, and also decrease reactive oxygen species. A large number of animal studies have been done on this, and basically all of them suggest an improvement of neurological function, reduce edema, increase angiogenesis, neurogenesis, and also decrease inflammatory infiltrate. And naturally, this was followed by a number of retrospective clinical studies. And basically, most of them showed improvement in terms of functional outcome and also reducing mortality. And you know, when we were looking into doing this trial using statins, we looked on the clinicaltrials.gov website, and you know, there was a study that was initiated at Hopkins back in 2008, and you know, that trial had to be terminated after 9 years because they only recruited one patient. And the issue there was that there was a competing trial, Misty, at that point. And so we reached out to the PI over there, and you know, having collaborated with us on a subsequent trial that we put forth to StrokeNet. And this is basically using the simvastatin study, prospective, randomized, placebo-controlled, double-blind phase 2 study using futility analysis, randomizing patient in a 1-to-1 fashion to placebo versus 80 milligrams of simvastatin for 14 days. And this would be stratified by site and also ICH score. And standard inclusion criteria for most ICH studies, we chose volume of 4 to 45 with a stability scan 5 hours apart. Patient would have to be randomized and within 18 hours and get drug or placebo within 24 hours. And standard exclusion criteria, we included patients who use statins within the past year. So our primary outcome was to see whether treatment with simvastatin is of sufficient promise to improve outcome in statin-naive patients presenting with spontaneous ICH using futility analysis. So, you know, our primary endpoint there was proportional functional independence at 3 months. And we had our secondary outcomes, unsurprisingly, looking at edema, looking at edema's extension distance, absolute volume, as well as relative volume. And, you know, standard secondary outcome measures, specifically in terms of specifically symptomatic ICH recurrence or expansion. because there was some concern regarding hemorrhage in patients using statin. And this was mostly from the Sparkle trial done years ago. In that trial, the patients with hemorrhagic stroke as an entry event had a risk of recurrent hemorrhage during follow-up, and that was more than 5.5 times with atorvastatin than placebo. There may be some correlation between the lower cholesterol level and increased incidence of hemorrhagic stroke, but that mechanism is unclear. Maybe it was endothelial dysfunction, maybe increased susceptibility to microaneurysm formation or rupture. Statins have also been postulated to inhibit platelet activity as well as coagulation cascade. However, majority of the trials have shown that did not actually show increased hemorrhage risk with statin use. This is from the heart protection study as well as meta-analyses involving more than 90,000 patients. The potentially increased risk of ICH recurrence with statins may be actually overstated, and the impact of the relatively short duration of statin therapy on recurrent ICH may be even less. So, for the study, we came out with a sample size of 338, and that's 80% power for the primary futility analysis, one size significance of 0.1. We had anticipated 42% of the eligible placebo patients will have an MRS 0 to 2 at 3 months. And this is based off of the data from the ERIC study. And we should use a null threshold of 12%. And basically, we had to inflate the sample size by a factor of 1.11 in order to account for a conservative dropout rate of 10%. And with all that, we proposed a 6-year study over 45 sites and total enrollment time of about 4 years. If the absolute difference in terms of proportional functional independence between simvastatin and placebos 0.12 or greater, then that would warrant a phase 3. Otherwise, it will not proceed to phase 3. And so we put this to StrokeNet and got reviewed and everything. But unfortunately, at that time, Saturn came out. And so, our study was put on hold until they complete this study, even though the patient population is completely different. So Saturn is looking at continuing or stopping statins on the risk of ICH recurrence within a 24-month period in patients presenting with lobar ICH while taking a statin. And, their safety outcome is MACE occurrence. They have their standard secondary objectives, basically looking at functional outcome, as well as how, ApoE genotype would affect the risk of ICH recurrence. So this was a prospective randomized open label blinded endpoint trial with close to 1,500 patients across 140 sites. So patients have to have a spontaneous lobar ICH while taking a statin, and patients have to be randomized within 7 days to continue or to stop statin, 1-to-1 randomization, no placebo, and required baseline ApoE genotyping. They also had an ancillary MRI study with nearly 900 patients, basically looking at the incidence of hemorrhagic markers on the end study MRI. And on the site PI here for the study. And so the target, in terms of the overall study is in the blue, and that's where we are at in the red in terms of randomization, pretty far behind schedule. But our goal here at Houston is to randomize 50 patients, and so far we've done 12. Actually did pretty well. We joined the study in July of last year, and we are now in the top 10. And so in terms of future direction here, to meet enrollment goals for Saturn, finish the quantum study analysis, get the manuscript out, externally validate the TBM model for hematoma expansion, and hopefully be able to incorporate it somehow in a clinical trial setting and move forward to Civic after Saturn is done. And so here are my bunch of collaborators. Happy to take some questions.
There's like an endoscopic strategy for evacuating ICHs that I saw as a medical student. It's called like the scuba technique, where they use continuous irrigation and aspiration, which could like eliminate some of the costs associated with NICO.
Yeah, that's the Mount Sinai thing.
Yeah.
Yeah, I hear it takes a long time. Like the surgery itself takes a very long time.
That long.
Oh, I don't know. That's what I hear. But I don't think people are really doing that anymore, right? I'm not heard anything more about it. And I guess we'll see what it's kind of like the Apollo, we'll see what the mind trial shows. But I've never used the scuba technique, but I just heard that, it takes a very long time.